So my name is Alexander Schroedter. I'm here for AIRS Medical, and we proudly present you our AI SwiftMR. SwiftMR is an image enhancement solution for your MRI scanner. And I want to start to talk about like the increasing demand of efficiencies and for image quality on your MRI scanner by just like having all the stakeholders within MRI imaging here shown. So my question to you in the audience, like whoever experienced an MRI scan, please hold your hand up. Yeah, do you remember your first time laying in the scanner, like in the tunnel, feeling like this anxiety or like the nose itching and like a little bit of discomfort? So like staying in a MRI scanner could be very difficult, and like for us, maybe everybody is healthy here, it's not that hard, but like for elderly people and for children or for people with pain, I think the time in the scanner values, and so that could be a challenge for patients, and the key point is time in the scanner matters for the patients. So when you move to the MR text, So in case like the patient moved within the imaging process, like you have repeated scans, you have a really reduced productivity, like when this has happened a lot of time. And maybe like when I'm talking to customers, like we have shortages within the workforce, which cause like frustration and burnout, and like if you have not enough stuff and then you have like to repeat a scan, this can break a lot of pressure to the MR technicians as well. So my key point here is as well, efficiency erase the workload of MRI techs teams by balancing patient care, workload and quality. So when we move to the third one, this is the radiologist, and obviously like better images are better for diagnosing, like giving you more confidence in your diagnosing, even though if you have like legacy scanner. So and it's good for him to have, or like for the radiologist to have high quality images, and to have it not only for 2D images but maybe as well for 3D images. And in the end, like the last one is the hospital manager. Like he has to take care for all the three stakeholders before. He has to make sure that the patients have good experiences. He has to make sure that like there are no challenges within the working conditions for their staffing. And he even though he has legacy technology, like he will be able in the future to overcome that. So I want to talk right now like how we are doing this with SwiftMR. So like you see a standard of care, like this is your normal MRI image, and we trained a neuronal network with 3 million data, and we are able to reduce the noise and sharpening the image. So and because of we are very good by doing that with our AI, like we are able to create pictures or images with reduced SNR and reduced sharpness. So right here, this is like on the scanner, like we can reduce we can accelerating the scan with a reduced SNR, and then we will bring it to our cloud and having the best image quality out of our perspective within the market. So like you have like efficiency gains on your scanner, and at the same time you have a better image quality, which could be benefiting all the radiology staff members. This turns out to results like that. This is a case study from a radiology center in Germany. So like you can see like they have like two different options between different Teslas. And you see like in the beginning, like what were the image acquisition time, and then the reduced acquisition time, and how many percentage like you can lower that. So like in this case, we're seeing like a decrease by 32% in your average time. So it's then up to the radiology or like to the center itself what to do with these efficiencies. Some are using it like for bringing the stuff back home earlier, or like to have like more space between the imaging, the exams. In this case, like they had the opportunity to scan more patients and to reduce the backlog. So what I want to show you is like that we bring value to all stakeholders within the imaging process. Like it's about anxiety and discomfort by having shorter scan times. We have, like, for the MR stuff, like the technicians, we have less repeated scan and enhanced productivity on the side. We have, like, lower scan backlogs. We have better image quality and maybe better revenue with more patient throughput. So what makes SwiftMR the top choice for your MRI scanner? Like, we have universal coverage of all body parts and all sequences. Means, like, not only 2D but as well 3D. You can use it, like, for all your sequences and protocols on your scanner. You can use it for all your MRI scanners, independently of the age, independently of the OEM vendor, independently of high field or low field. And you have a customization possibility, like you have 9 levels of denoising and 6 levels of sharpening. And, like, one of our biggest value propositions as well, you cannot use it only for 2D sequences, but you can use it for 3D sequences as well. So this is my last slide. I just want to show you, like, how easy it is to install it on your MRI scanner in case you're considering to drive your efficiencies on the MRI scanner. So we are working out of the DICOM data, which means, like, we are not on the scanner, we are behind the scanner. We're installing a gateway PC between your MRI scanner and your PACS system and bringing the DICOM data to this gateway PC. There we take off the patient data. So the patient data leaves through all the time within the center. We have an anonymization before we bring it into the cloud. On the cloud, you have the processing of the pictures, bringing it back then with high resolution and denoised images, having a de-anonymization and laid back into your PACS system. So at the end, it's just like having 2 nodes and a gateway PC. And with this, you will be able to enhance your MRI scanner and to have better image quality. So this is, like, my introduction to SwiftMR, and right now I would like to hand over to Professor Secchi, who will bring you, like, more clinical experiences regarding to that.
Thank you for the introduction. Okay, so now we are moving to a clinical issue. And so I would like to thanks to AIRS Medical that can avoid to do this research project that we are starting doing on my hospital. So before to go to our result, I just spent few words about the clinical context. So the clinical context, it's patients with acute infarct, and with MRI, with cardiac MRI, we can depict microvascular obstruction, we can depict alteration in tissue composition and myocyte integrity. That are the physiological markers more precise to indicate the presence of the infarct. And here you can see the progression of the infarct in the heart. So here there is no fibrotic tissue. Here it's present as subendocardial fibrotic tissue that grow, going a transmural infarct, so a real infarct of myocardium. We have another problem, it's the kinetic problem. So when we have a dyskinesia, so an alteration of the wall, the prognosis of these patients is worse than patients without dyskinesia after the infarct. And our scan protocol, MR scan protocol, of course, is based on chin evaluation, but most important, it's based on the tissue characterization with STIR images or T1 mapping and T2 mapping, and much more important, with gadolinium study to depict the presence of the fibrosis. And this is an example of an image, of STIR images. With this image, we would like to see the extension of the edema. Here you can see the bright part of the myocardium is the edema, and the edema it's a condition, the acute phase of the infarct. And with these sequences, we can measure the extension of the edema. Using contrast material, we can measure the presence of fibrosis, so the extension of the scar, and the physiological base on this approach is that the contrast material that we use, it's an extracellular contrast material, and when you have an acute infarct or when you have a scar, you have an increase of the extracellular space, so you have an increase of the amount of contrast material in this type of tissue, and so we have a late washout of the contrast material from this type of tissue compared to the normal tissue. So in this way, with an inversion recovery images, we can depict the difference between this is the scar, and between the normal myocardium. And this is an example of a very huge apical scar with a transmural fibrosis, like you can see here. This is actually not an acute infarct, but it's a chronic infarct with a remodeling and the aneurysm of the apex. But the clinical problem in the acute patients with infarct is to do a good prognostic stratification. So the clinical problem is to depict patients that go worse after the revascularization, so after the treatment of the infarct. And of course, the ejection fraction reduction is one of the signs that we can depict based on the contractility. But another most important sign that we can depict during the examination, it's the microvascular obstruction. And we will see what is this microvascular obstruction. And we know that this condition, the microvascular obstruction, it's related to the positive remodeling of the ventricle. And this is the positive remodeling. So when you have an infarct, you have a revascularization, but still persists a scar tissue inside the myocardium. And after here, this part of the myocardium can enlarge, giving an aneurysm. And after that, a rupture. So this is the reason why we want to depict this sign to treat the patients with high risk compared to the patients with low risk. And this is an example of a patient in acute phase with a large edema in the star images immediately after the stent revascularization of the coronary artery. And then 3 months later, there is no more edema because there is no more acute condition. And so this is a good sign. And here you can see a different stem of contractility than we have during the acute phase here and the late phase here after 3 months from stenting. And here, this is the most important images after contrast. It's a late gadolinium enhancement evaluation. So in the acute phase, you can see this black line inside the scar. This is the microvascular obstruction that disappear after 3 months. So this is important. But these patients with this huge microvascular obstruction have a high probability to develop an enlargement of the ventricle years later. So what we do practically in this research project, we use a software, it's a commercial software, CVI42, to measure the extension of the scar and the extension of edema. So we detect the endocardial border and subepicardial border, and then we detect a ROI in the normal myocardium here as a reference, and the ROI in the pathological myocardium, in the scar in this case, and in this case in the edema part. And then the software can measure the amount of the scar here and the amount of the edema here. And of course, we perform this for each slice from the base of the apex of the ventricle, so we can have an idea of the entire amount of fibrosis and the entire amount of edema and microvascular obstruction in patients in acute phase after infarct. But why we need to test SwiftMRI in this context? Because the idea is that if we can increase the image quality, if we have higher image quality, we can have more accurate post-processing, so we can depict better the extension of the fibrosis on the edema. But the real clinical reason is that we would like to have a better prognostic stratification of these patients. So this is the reason why we would like to have high quality images and high quality post-processing evaluation. And I give you a few examples of that. So this is a native image. This is an image treated with AI. So of course we have less noise, and this is impressive. And the same in the late gadolinium enhancement compared to the native to the AI treated sequence. And this is an example of the difference in terms of post-processing between the standard images and the AI ligand enhancement images. So as you can see here, there is no microvascular obstruction depiction here, but here we have an identification of the microvascular obstruction. That is the black line that you can see here. So with the higher quality, we can depict better the microvascular obstruction. And as I mentioned before, the microvascular obstruction is a sign of ROST prognosis of this patient. So this is the reason why it is important. And this is just to see you the scar here, the bright line here, and the black line inside the scar. This is the microvascular obstruction. And this is another example of inferior fibrosis here in the standard images and in the AI images. And you can see that when you do a post-processing, the post-processing with the AI, it's a little bit more accurate and precise than the standard images, because we have less noise, so the software runs better than standard images. And this is the same concept, but regarding edema. This is the extension of the edema. But moving out our result, actually we have just preliminary result. The project starting a few months ago. So we have 25 patients treated with acute infarct, and we can see that there is no difference in term, considering all the patients, in terms of ligand enhancement amount, in terms of percentage, comparing AI to native images. But we have a difference in terms of edema extension. So we have an increase of the extension of the edema using AI. And this is the graph representing the difference of edema measurement compared to late gadolinium enhancement measurement. But so we believe that with this software, with the increase of the image quality, we can improve the quality of late gadolinium enhancement and edema enhancement. But of course, we have no reference standards in this case, because you need autopsy to have the reference standards about the gram of fibrosis or edema. And so the target of this project and the future direction is to see the clinical outcome and to see if with type of post-processing we have more accurate in the prognosis of these patients, looking for the clinical outcome. So the clinical target, it's very important for this patient, because you can change better the therapy in patients with high risk to evolving in aneurysm and ROS prognosis. So thank you very much for your attention.
Thank you both. We have a question from the online audience. I think probably best for you to answer this one.
Can I use the microphone up there, or should I go to
If you go to the stand. Yes. The question is from Anonymous, and you'll figure out why straight away.
Go ahead.
Who's going to take responsibility if data is lost in this image processing step?
Yeah.
Other AI doesn't tend to touch raw data, so will clients be afraid to have applications like this editing raw data?
That's a really good question. Actually, a neural network can only do what it's trained for. So like our neural network is only trained for detecting noise and reducing noise and sharpening. So by doing that, like the AI is trained to use 7 slices of the MRI images, like to try to figure out what is noise, which is irregular, and what is anatomy, which is regular. By doing that, like he can only do that. So for this reason, like there's no interpolation. Like if there are motion artifacts within the initial picture, it cannot be removed because it's only trained to denoise and to sharp.
Okay, so to reassure Anonymous, the raw data is not lost.
Okay, you're welcome.
Okay, brilliant. Any questions from the audience? Please do feel free to step forward. Otherwise, you have a booth. Do you want to tell me?
Yes, it's in the AI section number 39. So AIRS Medical, you can come over. Like we have various DICOM images, like for all the scanners. So you're very invited to come over. Like we show you.
Okay. Well, another round of applause for the AIRS team. Thank you so much.